So today, this is a very good lecture. We are having Mr. Pawan Kalyan. He is a allergy specialist and pediatrician from Vijayawada, and he will be advising us, will be guiding us on asthma and mimics. And also Dr. Sunil Wagmare, he is a chest physician from Breed, and he will be guiding us on difficult to treat asthma in adults. So this is a very good combination of lectures, and we all must thank our IMA president, Dr. Anurag Pangrikar, who has given this opportunity. And I welcome all the pediatricians and physicians for attending this CME. And I thank at the onset, I thank Dr. Pawan Kalyan and Dr. Sunil Wagmare. And I will hand over the mic to Sachin without wasting any time. Thank you.
Thank you, Joshi sir. Now I request Dr. Tukaram Munde sir to chair this session and introduce our first speaker, Dr. Pawan Kalyan sir. Tukaram, over to Tukaram.
Good evening, everyone. Thanks, Sachin, for introducing me a well-known faculty from Andhra Pradesh, Dr. Pawan Kalyan, who is a MD FSCI, fellow in pediatric pulmonology and sleep medicine, in allergy and clinical immunology from Chennai. He is a professor in PCIMS and Research Foundation, Uttapalli. Presently, he is a secretary of IIP State, treasurer IIP Medical Education Chapter, and joint national coordinator of IIP JG ECD project. He is he was a executive board of Central IIP for 2020 and executive board for IIP Respiratory Chapter in 2019 and 2020. He was a national advisory board member of Indian Pediatrics in 2020. Now presently working as a consultant in pulmonology, allergy and sleep specialist in Pinamanya and Harni Hospital in Vijayawada. Sir, I will give you mic to continue for the next session.
Thank you, sir. Thank you very much. At the outset, I would thank my senior, Dr. Sachin Jetlia, sir. When I was doing my residency, sir was a fellow, and I've learned from him the neonatology tips. Now it's my honor that sir has called me as a pediatric pulmonologist to give lecture on asthma and its mimics. I thank you very much, sir, for giving me this opportunity. Without wasting much time, we would go to the asthma and mimics. The reason we have chosen this topic is that each and every patient who comes to the OPD who has a cough or a noisy breathing would be started on nebulizer. So I just wanted to emphasize that there are so many things we need to understand before we give a nebulizer, because patients also get accustomed. Why should I come to a doctor? The only thing is that the nebulizer I have at home, I will do it. So the nebulizer is not the treatment. Let us go and understand. So I have non-disclosures, and let us start with the asthma definition. So initially the definition has evolved over the time. When it started in 2007, the definition was only the reversibility and so on and so forth. And in 2019, the ZINA has come up with a definition, which is now asthma has become a syndrome or a constellation of symptoms. So this is a heterogeneous disease which is characterized by chronic inflammation. How it is being defined is history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough, which may vary over the time and intensity. Now to add on, they have come up with, we have to show something of variable expiratory airflow limitations, which is in the form of spirometry. So the new ERS guidelines have come up, and also the IAP also has emphasizing on doing spirometry for each and every child to show the reversibility to the parents, to understand, see if you give, because we have two types of asthma, which I'm not going to talk in detail because it's in the pulmonologist purview. That is TH2 high and TH2 low. That is T helper cells type 2 is an eosinophilic type of asthma, where your corticosteroids would work. Whereas TH2 low asthma is a neutrophilic type of asthma. So the endotypes and the phenotypes, there is a lot which is going on. And there are the biological markers where you can give anti-IgE and so on and so forth for a pulmonologist, where you have a resistance case, then you need to look into. So I'll just try to emphasize our pediatricians and the general physicians that there are lots of things which have come up in asthma. Today I'll start with a case with an asthma, and I will take you to different scenarios how that is being taken off. Now I also wanted to talk about little on modified asthma predictive index when the people come. This is for children younger than 3 years of age. So nowadays, what the modified asthma index says that you should have more than 4 wheezing episodes per year. Then only you will first try to, without 4 wheezing episodes, you cannot start of using a modified asthma predictive index. Why? This is because whether this would be later turning into asthma. If your score is more and this is fitting into the criteria, they become an asthmatic at 5 years of age. So till 5 years of age, we don't have any demonstrable way, that is your spirometry, to do. So what are the major criteria is parent with asthma, physician diagnosed atopic dermatitis, or sensitization 1 aeroallergen, which are present in your aeroallergens of different types. That sensitization is good by skin prick test. Now, minor criteria is wheezing, which is unrelated to cold, and you have a peripheral blood eosinophil of greater than 4%, and sensitization to food allergens. So this index is positive when children meet at least 1 major criteria or 2 minor criteria. So either parent with asthma or a physician diagnosed atopic dermatitis or aeroallergen or any of the 2 which I have mentioned. So there are a number of guidelines. I have not put each and every because Japanese Thoracic Society, Canadian Thoracic Society, there are a number of thoracic societies, including our chest, Indian Chest Thoracic Society, but it doesn't give guidelines for asthma below 18 years. So IAP has come, and in the standard treatment guidelines also, you have seen there is a different under 5 wheezer is an asthma. So we are all getting confused. What guidelines? Guidelines is only help us to understand, and you have to have, because now everything is a personalized medicine. So you need to treat the patient according to him, and we have to go ahead. Now let us see one of the first case. This is a 6-year-old Ram who has come with history of recurrent cough, which is associated with increased work of breathing because it is like a wheezing since 3 years of age, having frequent episodes since last 6 months, and he has a family history of atopy. Sorry, mother is a known asthmatic, and there is history of tobacco smoking in the grandfather who is living with them since the last 6 months. And the child was using initially nebulizers and cough syrups for the cough. Now the mother's, sir, I've been using nebulizers and cough syrups. Still, my child is having this cough with increased work of breathing. In the past history, he had never had previous admissions to the PICU. He was only coming to the hospital on an OPD basis, taking nebulizers, and he purchased his own nebulizer and getting, whenever he gets a cough, he gives nebulization. The birth history is a term child, appropriate for gestation age. There is no history of any NICU stay. And the anthropometry weight is 15 kgs between 3rd and 10th centile, and height is 112, 25th to 50th centile. Please do look into each and every asthmatic, his anthropometry. That will tell us whether he is controlled, partly controlled, or uncontrolled. He doesn't have any dysmorphic features, because what I am looking here, the dysmorphic features is because of 6 years old, you have associated comorbidities like allergic rhinitis, who may have a tonsillar and adenoid hypertrophy, which may also have some amount of obstructive sleep apnea, where you have a different, the spaces would be, adenoid faces could be seen. So it doesn't have any of such category. Vitals was, except for mild tachypnea, and the saturation was, and the room air was 95%. And on examination, there was a bilateral terminal expiratory wheeze. Now, what would you do? Would you do a CBP? Would you like to do a chest X-ray? Would you like to do a serum Ig level or a skin prick test, because you have read in the modified because of the criteria, and a spirometry? Now, if anybody would like to chat or put an answer, that would be good. So, is there a role of a CBP? Still today, because eosinophils they are looking into, and chest X-ray for the first time, if you are in a doubt, or you can do a chest X-ray, but having so many recurrent episodes, there is no role. And total serum Ig level, as of now, in today's data, we say that they don't have until unless this is a type 2 high eosinophilic type of asthma, which has not been responding, and you have a high Ig level, you want to give anti-Ig, then only you will do. And skin prick test, generally in Western world, sorry, in the Western world, for every asthmatic child who had been to an PICU admission, they do a skin prick test because they have a standardized allergens. Now in India, we don't have much of the standardized allergens. Previously, they used to be. Now you cannot do each and every blood test having so many. They bring the reports. Sorry, reports with different IG levels. So this my child is allergic. See the IgE, serum specific IgE. You need to correlate with the clinical history. There could be sensitization, and the sensitization, if you have an associated symptom only, we have to take into picture. So the gold standard would be skin prick test if you have a standardized allergens. Now the most important thing, what each and every guideline is talking about, spirometry. So you need to do a spirometry for each and every child more than 6 years. Give an attempt. The first attempt may be a failure, but still we do a spirometry for more than 5 years of age. In younger also we can do, but 5 years and above. Now this is the spirometry which we have done, and which shows an FE1 by FEC of 74, FE1 of 79, and FEC of 93. So you can see the FE1. So anything less than 80, you need to get worried. So the number 80, you remember, FE1 by FEC is 74, which is less than 80. FE1 is 79, which is again less than 80. Whereas FEC is normal, which is more than 80. So when you see a spirometry report, you need to know whether it is acceptable and repeatable. So when at the end of the report, I would show, but when you need to interpret the report, so you first see the FE1 by FEC, which is low. FE1 by FEC, which FEC could be either decreased or normal, whereas FE1 in obstructive is low. So there are two criteria. So FE1 by FEC is low and FE1 is low, which suggests there is some amount of obstruction. So whenever you do a spirometry, the report would be like this. You need to see the comments mostly. The spirometry is reproducible and acceptable. So it showed FE1 ratio less, FE1 25/75, and the most important, which I haven't shown you, is that increase of your FE1 post bronchodilator response more than 12% or 200 ml. So it is 29%. So there is significant bronchodilator response. So there you can show, and you can look at the loop itself. See, this is what it looks. The child was coughing, but if the child is not coughing the first second, you can stay. So this is between the coughing, you get such type of spirometry. So acceptable. So this PFT was consistent of asthma, and the child was started on levosalbutamol because the child was wheezing right now. You need not give nebulizers. There have been n number of studies which shows that when the child is mild to moderate, you can give with your spacer, with what you call with or without mask, 2 puffs. So you can give for less than 6 years, 6 puffs maximum, and for more than 6 years, you can give 12 puffs in case of emergency. So if the child is unable to breathe through the spacer, then you will give a mask. So 2 puffs every 4th hourly, and the budesonide 100 microgram, 1 puff twice daily, because it was showing a significant bronchodilator response, and it's been for a long time. And according to the new GINA guidelines, you need to start on with low dose of inhaled corticosteroid. Now either you have budesonide or a fluticasone. It all depends upon the choice what you take. Now, please do understand, whenever you give the treatment, it is our responsibility to show and demonstrate how do you take a spacer with the mask or without mask. So there are certain spacers which are purely transparent. That is, you need to make use of valved one so that it is only one way. And the most important is that whenever you teach, you need to teach from the step 1, that is shaking of the inhaler, priming of the spacer when you have not used for a long time, and how to breathe. Most of the times, as I go ahead in the same case, I haven't questioned, but I will tell you the other ways also. And the budesonide also, because I haven't started any, because the child was not in any exacerbation, so we have not started any oral corticosteroid. Now, I have also given you in the history that the grandfather was smoking. सब लोग बोलते हैं कि grandfather घर पे नहीं smoke करते, but बाहर smoke करते. Please do remember, there is a passive smoking, that is primary, secondary, and tertiary level, where primary is in the face-to-face, passive is in the same room, and sometimes whenever you smoke, the dust particle would be there on your shirts. So the smoking and agarbattis, then you can have mosquito coils, everything. These are all the environmental triggers which will cause. So whenever you take the history, if he's coming for recurrent exacerbation, kindly look into his associated comorbidities, which there is no sign of allergic rhinitis because he didn't have any open mouth breathing or recurrent sneezing, because there are allergic rhinitis could be two types. One is a runner variety, the other is a blocker variety. Runner is completely running nose, blocker is he has a disturbed sleep, bed rotation, he has inferior turbinate hypertrophy, cobblestone appearance when you look into, because they don't come. When you ask the history of disturbed sleep in the form of bed rotation, teeth grinding, snoring, definitely they would say. And the other issue, when you have so much of obstruction, they can also have a bedwetting, nocturnal aneurysm. It's not always the kidney related issues, but also sometimes your OSA can also, because of very lazy to get up, they pass the urine. So this is what you need to give. And the other thing is that levosalbutamol, after 2 days, the child would come up with a follow-up completing of your levosalbutamol, or because you have a dose counter, kindly check into the dose counter. How many puffs have been used? You say 2 puffs, but the patient is taking 4 puffs. So you need to tell that you cannot give because you are down regulating the beta 2 receptors. So you need to tell them when to take, how to take, and please do check the dose regulators. And each time when they come to the hospital, they need to bring their equipment with them. The most important thing which you need to counsel them is that the cleaning of the equipment. I re-emphasize and again tell to every pediatrician or every person here, because whenever a patient is not responding to treatment, you as well, everybody know you need to look at the compliance. If the compliance is good, look at the technique and the way they are doing. Most of them don't know that you need to wash it with a light detergent and not to wipe the spacer. Most of them who come to us would wipe the spacer. So who comes to us by wiping and they say that, sir, we have been using properly as we said. But when you ask the history, did you wipe? Yes. Once you start wiping, the zero static, where you have no electricity, you are making all the drug to be staying inside the, what you call, the spacer. So there are different companies. Max Spacer is there. You have your zero stat Cipla space. It all depends upon how comfortable. If you want to demonstrate, it all up to you. It is a personalized choice. You need to show them that valve has to be opened when he is inspiring. Until unless you teach them, it is not going to happen. So kindly tell them this is what you need to look into. And as you know, once the child is doing good, you need to start tapering after 3 months your inhaled corticosteroid according to 25 to 50%. So the best way was fluticasone. Fluticasone was not available because it all depends upon the country which you have been trained. The UK people use budesonide, or American people, Australian people uses fluticasone. So it all depends on how experienced it is. Not that this is better. There are not much head-on-head trials, but they say the fluticasone has better efficacy. We don't have much head-on-head trials. And each time when they come with follow-up, we generally need to do a repeat spirometry to show how is the thing. So whenever the child come with again and again recurrent exacerbation, please look into the technique compliance as well as the machine. And also please do ask the environmental trigger and look for each time the associated comorbidities, which sometimes may be sudden weight gain, obesity, and so on and so forth. And you please try to write how many doses of oral corticosteroids each time we are prescribing. We need to be very vigilant. Is it steroid dependent? Because sometimes you have a T2, TH2 high, then you need to think of the other thing and you need to refer to a pulmonologist. So this is the simple of simple case of asthma who comes to us. More than 6 years, I was able to demonstrate that there's an obstruction, and after bronchodilator, there is a huge increase. And I've shown this report to the mother, got convinced that the inhaler is the treatment of choice, not the nebulizer. Because if you give a nebulizer, 25% goes only to the lungs. Why do most of them is in the oral deposition? The inhaler would go much more deeper. So you need to teach the technique how they use the inhaler. Now, kindly keep this dose chart with you because we don't know how we are going to write. Because budesonide, if you start with 100 microgram and keep on increasing to 400, you need to see 12 years and 6 to 11 years. You see budesonide respules and DPI more than 400. So 200 twice 400. And if you give more, it becomes high. So we need to see whether we are, because we keep on increasing when the child is not responding. There are certain things which we need to know. So keep the common things. We use budesonide, we use fluticasone. So you need to look into the doses when we prescribe, whether it is in the low dose, medium dose, or high dose. We have to be smart. Each time we cannot mug up it. Is the best way is to keep this in our desk and see how they are doing. Now, a question to all of you. In children, which of the following indicates a diagnosis other than asthma? Is the absence of wheezing, recurrent cough or wheeze that improves with salbutamol, recurrent or prolonged cough, wheeze that does not improve with systemic steroids, or normal spirometry findings? So you can keep on, you can just type in the chat box. So the answer would be recurrent or prolonged cough, wheeze that does not improve with systemic. Normal spirometry findings could be there in an asthma also. Now let us see when you need to suspect an asthma mimic or a masquerader. You have symptoms despite the treatment with your levosalbutamol. Again, please do check with the complaints and the way they are doing. Treatment with systemic steroids. And you have looked into the adherence and everything. And you keep on escalating the controlled medication dosage that I said 200 to 400, still the child is not been there. And also please do note, as I said, environmental exposure, which includes your mostly your tobacco smoke, agarbattis, then your mosquito coil, sometimes your construction, sometimes a factory site, something or the other. Because when you have and difficult to treat asthma, which would be taken by the next by the chest physicians, where they would, in the Western world, the nurse would go and see their house environment, which we don't do. But at least we can ask them. And most of the thing is removal of triggering exposures. People would say, if I eat banana, if I eat orange, if I eat something. See, generally, you won't get anything by eating. If I eat an ice cream, if I eat a chocolate, this would trigger. What we have seen till date, the studies is that it is the coloring agent which would be coming, but not to the exposure. There could be some cross reaction. So you need to be very, this thing that eating of certain foods would not, except for the seafoods, which we think of a food allergy very common and anaphylaxis. Rather than that, rest of the things are not much common. And you should think of exclusion of steroid resistance. When you have such things, think of TH2 low and a neutrophilic type of asthma. Now let us see a case. This is Master Krishna, who is an 18-year-old, having shortness of breath and wheezing since 9 years. And this is being there since 2012. And his triggers being cold weather and dust mites. The dust mites are present. The allergens are only 4. That is, the dust mites are present in your mattress and pillows. There is history of nasal allergy and disturbed sleep. And he was not going to college because of 18 years old. He came way back. This is a 4 years old back, because I want everybody to understand that whatever we see is not an asthma. He had history of unconsciousness 2 to 3 times, but he does not remember what is the exact triggers. It was an anaphylaxis or not, because we couldn't estimate. And he was having frequent visits because of this, so much of noisy breathing and wheezing. So when they started, because the acceptance in a peripheral area where he was very far away, was started with oral medications, not like cough syrup. Then they have started with inhalation therapy. Initially responded, then later he was not responding well. And he was being labeled as difficult to treat asthma. Given whenever he was having acute exacerbation, we treated with IV steroids, nebulized inhalation therapy, IV antibiotics, including IV deriphyllin and aminophylline were being given. Now, what is the next step? Would you like to do a CBP? Would you do an IgE level, chest X-ray, chest CT, bronchoscopy? Because the child was not responding to the way he was supposed to be. Would a CBP help? Plus or minus? Because until unless you have a triggering bacterial infection, then only IgE level, yes, you need to think, because you may have certain things called, when you have an uncontrolled asthma, you need to, in an Indian scenario, think of ABPA, that is allergic bronchopulmonary aspergillosis. So CT scan, plus or minus when you don't have anything, external compression. Bronchoscopy, yes, when the child is not responding. Now the CBP was within normal limits, eosinophils were 1%, total IgE is 2091. As I said, serum IgE, when it is high, we would look for the ABPA concern. So Aspergillus fumigatus for serum IgE was 0.75, not, it was not to the extent, this thing. And spirometry showed mild obstruction, bronchodilator response, and CT chest was normal. Now they have done. Now please listen to the audio. If everybody are able to hear, please do listen. So I think if you are able to hear the wheezing sound, that's what he was being complaining. He was having so much of wheezing like this. And if you see the saturation was 99%, it's such a wheezing. Is the child in acute exacerbation? No. Does the child have wheezing? Yes. Now what is here next step? Are we treating? Because if it is being labeled as difficult to treat asthma and being given all the sorts of therapy. So when you see such an adolescent type of people, you need to think of some other thing which on a bronchoscopy would definitely say this is a mild obstruction, the scooping, there is an improvement. So when you did a bronchoscopy, this is the normal vocal cords. Vocal cords during expiration should be closing and during inspiration should be open. This is a paradoxical vocal cord movement. That is, so the in recent terminology is exercise-induced obstruction, where laryngeal obstruction, when you ask them to do some exercise and you do a scopy, this is what you see. So paradoxical vocal cord, this is called as vocal cord dysfunction. So this child is having both VCD as well as asthma. Very commonly we see this in adolescents. Whenever they have a stress, some triggers would be there. That is the reason when during examination, during this thing, this child would have so much of wheezing and had a panic attack and stopped going to college. So whenever you see such things, so think of the other things. So this, you could be in the vocal cord dysfunction. You may see the intermittent inspiratory extrathoracic airway obstruction. So you can see the anterior when it is there and closed. What is the difference between asthma and vocal cord dysfunction? The onset of vocal cord dysfunction, any trigger, it is very seconds. The duration would remain only for seconds to minutes, but sometimes because he has both asthma and VCD, this child is in prolonged. And the dyspnea, what you are seeing would be an expiration, but vocal cord is an inspiration. Nocturnal symptoms are usually absent for vocal cord dysfunction, and the, as you know, it is at the throat. Inhaled therapy, how much ever you give is ineffective. You need to calm down the child. When you do, you can see this on your spirometry where you have a flattened inspiratory loop. When you take the upper one is lower one is inspiratory, when the child takes a deep inspiration, you see a flattened inspiratory loop. And oxygen saturation with attack, as I showed, the child had 99%. Whereas in an asthmatic child, you would see a reduced one, and a flow volume group, which would be seen as a scooping, would be there, and inhaled therapy would work better. And is also the lower airways which is getting affected. So this is what you see scoping. So what test finding is diagnostic for your vocal cord dysfunction? Less than 12% increase in FE1 after bronchodilator, flattened inspiratory on spirometry, or bronchoscopy demonstrating erection of vocal cords during inspiration, or bronchoscopy demonstrating abduction and vocal cords during exhalation. If you can type, that's good. So somebody has put 3 and 4. You cannot have this thing because it's only the adduction of vocal cord during inspiration. Yeah, this is also right. I do agree, because once you abduct, the vocal cords are open during, correct. I'm so sorry. So which of the following symptoms are more predictive of asthma compared with vocal cord dysfunction? Is it the dysphonia, throat tightness, wheezing, cough, or shortness of breath? Everybody have been expert. Now that is a wheezing, which would be definitely suggestive of. So please do remember, this is associated with your psychological problems. So they have a higher levels of anxiety, anxiety-related diagnosis, academic and athletic overachievers, these you could see. And you can sometimes see a spirometry-induced bronchospasm and they get so panicky. So adult VCD, this is because there is an adult pulmonologist who would be talking much more. So there is no overall increased amount of stress. 23% had no psychosocial disorders. So how do you manage one? The most important thing, you know that this is a vocal cord dysfunction, but how do you manage? Basically, the multidisciplinary approach. He may have an associated what you call obstruction, which suggestive of asthma, but vocal cord dysfunction as such is you need to calm the child. So that is, you need to have a speech therapist that is pursely breathing. Whenever he gets excited, ask him to breathe the lips. That would reduce the noise and he would be much. So you need to, because we don't have a speech therapist, the exercise which I've taught, and you need to relax and breathing covering inspiration as exhalation, which I showed. And you need to address all the comorbid conditions like your gastroesophageal reflex, postnasal drip, which would be causing irritation. Whenever they lay down, they have a cough. And most important is like a stress level has to be taken care of. So whenever he's been told all the meditation, everything, and when he's ever having this, after teaching all this thing, the child has been responding well and has become a good adult. I think now he's 25 or something, going good, going to job. Now see the other case. This is Master Lakshman, 6-year-old with asthma, because he has been diagnosed with asthma and also has an allergic rhinitis. He has recurrent cough, wheeze, and also there is an increased work of breathing. This has been triggered by recurrent upper respiratory tract infection, change in weather, whenever he does an exercise or seasonal changes is being triggered. Intermittently, this child, whenever he has this, has a recurrent barking cough without stridor, and also had desaturation during those episodes. When you see if there is a desaturation, think something. And this child has been treated with nebulization, later with spaces MDI prevention and control therapy. In spite of that, this child was having such cases, and there was only mild improvement. In the past, when he was at 6 months, he has been admitted twice because of respiratory failure. 6 months and other at 1.5 years of age. Now, what do you do? Do you do a chest X-ray? Do you do a spirometry or do a bronchoscopy? By this time, if anything abnormal, it won't be there. So you could, some amount of narrowing or anything would be there if external compression tracheomalacia would be seen. Spirometry, yes, if you could do, and the bronchoscopy when the child is not responding to the usual way of management and you have some doubt, go ahead. So please listen to the cough again to this child.
Book, sorry. Last time.
So this child having this type of barking cough, whenever you hear such barking cough in your OPD, having such things, I would show you again the video of the bronchoscopy and you will know how difficult, because these are the difficult people to be managed. So we have done a spirometry, which showed FE1 by FEC. It's to be normal. FE1 is also, these are all the normal, and there's change is also normal. So it looks like a normal spirometry. And we have done a bronchoscopy because the child had 2 episodes in such a way. So when you see such a bronchoscopy, you can see the posterior wall is being touching to the anterior wall. This is a slip type of this thing. So which, see, you can see, I would show this is a type of, so you are able to see the crescent shape of this thing, which suggests of tracheomalacia. So the child can have a laryngo-tracheo-bronchomalacia until else you do, when the child is not been responding well, until else you have a vascular nature or pulsatile nature, external compression. This could be a congenital. It could be either primary or a secondary. So the tracheomalacia is how do you, in the inspiration, how does it look? In the expiration, see how it's been. So this is the weakness in the air wall due to reduction or atrophy of your longitudinal elastic fibers. And they are more susceptible to collapse. Whenever you have a triggered upper respiratory tract infection, the triggering is so severe that, see, the airway will be so collapsed. That is the reason he went into impending respiratory failure, and they have stunted it by putting a tracheal tube, endotracheal tube. And because of the tracheomalacia, you have retention of secretion. They will not be clearing up. So they may have associated pneumonitis because of the bacteria may get superadded there, or they get lodged there and get more infection and more secretions. And they cause more and more bronchopulmonary infection. So there is no universally accepted definition for, there is grade 1, grade 2, grade 3, but there is no universally accepted definition. Nowadays, for an adult pulmonology, when you see such type of tracheomalacia, they would be doing a stunting Pediatric age group, they just started. You need to know there are certain biodegradable. This is all the interventional pulmonologist way. But for a general practitioner, when you're not happy with the way you're supposed to be and having such type of cough in the background, please do think that this is a barking cough with no other thing. Think of trichomalacia. Take home message. So asthma versus trichomalacia. Dyspnea is seen both during expiration. Wheezing is a high pitch, whereas a trichomalacia would be a low pitched. And you please do remember, this is a monophonic one. Like a foreign body which has a monophonic wheezing, trichomalacia do have a monophonic wheezing. Stridor is absent. Obstruction is all lower areas. This could be tracheomeningeal larger area. Flow volume group is again reduced in expiratory. And beta agonist therapy would reduce your asthma, but it would collapse more and it would aggravate the problem. So whenever you see for trichomalacia having an acute episode, if you give a bronchodilator therapy, that will aggravate. So you need to be very careful when doing this. Now coming to case 4, which is very interesting. This is a 4-year-old Miss Sita having recurrent cold and coughs in 6 months of age, worsening since the last 6 months. Having work of breathing, that is increased work of breathing, and there is a post-stress vomiting. The child would vomit out the food whenever the child coughs out. And there was a construction which was going on nearby their living area. There is no history of any ear discharge or steatoria because the child is having recurrent cold and cough. There is no history of any recurrent infections requiring IV antibiotic therapy. And there is no history of any sudden deaths in the family members. Now, significantly, it's a 3rd-degree consanguineous marriage. Eldership is absolutely normal. Birth history is a term appropriate for gestation age. There is no history of any NICU stay. Developmental history is absolutely normal, gaining. But the anthropometry weight, she's at 3rd centile. How much ever she is not gaining weight. They are so fed up because every month she used to go to hospital taking nebulizers, inhalation therapy. And the child used to come back and again and again and again. On examination, there is no disformity features, but there is some amount of open mouth breathing, inferior tablet hypertrophy. There is an allergic rhinitis. Less than 6 months of age or 2 years of age, you need to be very careful when you diagnose there's an allergic. The youngest age, yes, when my boss, Dr. Nagaraj, said that the youngest age would be 6 months, you can see. There is no clubbing and there is a bilateral wheezing heard throughout. Now, the treatment history, initially they started with nebulizers, then went to inhalation therapy. Given being levodopa salbutamol SOS inhalation therapy whenever the child wheezes, and they've started with the budesonide as a routine because it predicted into modified asthmatic index more than 4 wheezings per year, and there are family history which I haven't mentioned, and it was fitting into. And they've started on low dose inhaled corticosteroid, not responded well. Good strict adherence, followed the treatment. In spite of that, the child is having recurrent wheezing, coming back and again. So they have increased the dose to 200. That is, they have gone to highest dose because in spite of the highest dose, the child didn't respond. They have changed it to LABA with short-acting beta-2. In spite of that, the child is having recurrent wheezing. This is the stage where a general pediatrician has referred because in spite of all the management, you cannot go to LABA with. Whenever the child is not responding to the usual management, there is something which is fishy which is going on. And this child was receiving repeated short bursts of oral corticosteroid because the child was having high wheezing. It was like TH2 high, what they were talking of because the child was responding to this. So in spite of the above management, the child Sita had persistent. I stopped everything. I've started treating because there was a construction, everything, allergic rhinitis, given her inhaled intranasal corticosteroid for turbinate and leukotriene receptor antagonist. Initially, the child was much better. Again, after 1 month, the child came with severe wheezing. Saturation has been maintained. Thriving well, no clubbing, 3rd-degree consanguineous marriage. You have only certain few conditions which you need to think of. So, how do we proceed? CBP, serum IgE, because of child was receiving repeated bursts. Is it the TH2 high one? Skin prick test, any allergic manifestation? CT chest or anything else? So CBP was normal. Serum IgE we didn't do. Skin prick test, there was no allergic otherwise which has been there. And yes, we did a CT chest. even though there is no clubbing. I've taken the place where you can, I'm just focusing on 2 areas where you can see some amount of this is a bronchiectasis changes and there is a mucus plugging there. So in an asthmatic child, because of this modified mask, you could try a multi-triggered wheezing with acute exercise, they would not see such. So there is something which is going on. So it is not a typically asthma how we treat, because each time the nebulizers are systemic. So there are only certain conditions you need to think. Your mucociliary problems, or your cystic fibrosis, or your innate errors of immunity, inborn errors of immunity. That is your primary deficiency, otherwise called as. So the CBP didn't show a major change. When you have a lymphopenia, neutropenia, definitely, and there is no family history, being a 3rd-degree consanguineous marriage. Now we are left with only 2 things: either mucociliary problems or your cystic fibrosis. By this time, if you had, the child would have presented with meconium plugs, steatoria, not thriving well, and some amount of clubbing if there is so much of recurrent respiratory tract infection. Again, we are left with only one, that is mucociliary problems. What is the commonest mucociliary problems? Is your primary ciliary dyskinesia. For that, there are only certain centers who do a nasal brushing, and you do a genetic or exhaled, fractional exhaled, nasal nitric oxide, where you need to do, but every center do not have. So I will show you certain videos. This is the typically how, if you do a nasal brushing, looks like. Everybody, you can see the cilia are beating, see the movement. Everybody produce mucus, including you, me, every kid. But because of good ciliary function, the mucus gets, we swallow it and it goes up. In the second video, you're not able to see the cilia being moving at all. So this is one type of primary ciliary dyskinesia where there is absence of movement of cilia. Now see the other variety where the cilia are moving, but moving randomly, this way, that way. So you need to see that the cilia should move in the same one way, because it has to clear. When you sweep the floor, you cannot sweep from one, you sweep from one end to other end. In the same way, we do that. So where I have worked with Robert Wood, who is the pioneer of pediatric bronchoscopy, whenever he has a doubt, he would put instill a drop of the saline and look how the drop would be moving. If the cilia are good, the pace he would look with experience. That's a crude way when you don't have. But because the child is unaffordable, so many tests, so I have directly gone to genetic analysis for this child, where you could see homozygous likely pathogenic variant of consistent with phenotype detected, that is your ciliary dyskinesia primary. When you have a doubt and the child is not been responding, so I have a case series of 5 at different onsets of this. We have diagnosed this primary ciliary dyskinesia. So all the patients with this child can, because the cilia has not been functioning, you may have an airflow obstruction, you may have an associated what you call wheezing, that is, you can have the mucus plugging and obstruction, which the child may present with wheeze. But the primary cause is the non-function of cilia because of mucus is being there. So even though you are giving a treatment, you need to clear the secretion. So at the end of the day, the management for a primary ciliary dyskinesia is your airway clearance technique. A good chest physiotherapy is needed. Once we have tested chest physiotherapy, the mucus is being getting cleared. He may have an associated allergic component. You may have all these things, but the primary problem is the primary ciliary dyskinesia. You may have all these associations. That is the reason he was partially responding to your inhaler therapy. Okay. So this would be my last case. This is a case 5. This is 16-year Miss Renu. I just wanted to tell you there is a little ray of hope for asthma. People would ask whether is there any treatment? Would my child have to take a lifelong inhaler therapy? This child is 16 years, Renu, has frequent history of cold and wet cough since 5 years of age. Very frequent attacks during winter season, and some are very infrequent attacks. He has history of dry skin, itching of eyes, that means allergic conjunctivitis, and also has an allergic rhinitis, blockeritis because of throat clearing sounds. having intermittent morning headaches, that is the blocker variety when you have an allergic rhinosinusitis. And also has an exercise intolerance. Whenever she exercises, she develops this bronchospasm. And there's a family history of asthma in paternal grandfather. Till 10 years of age, managed with again oral medication. Then of 10 years of age, started on nebulizer and inhaler therapy. Undernourished, average height, no clubbing, inferior turbinate hypertrophy, cobblestone appearance of the pharyngeal wall. Chest at the time of examination was absolutely clear. Rest of the systemic examination unremarkable. So the investigation, we thought CBP, chest X-ray, and we did a skin prick test because of the history, perennial one, and we could see a positive skin prick test for your house dust mite. So whenever you see a positive skin prick test and having associated, that means this child is not sensitized and having. So if you see the studies of late in 2018, which has been published, they looked into various pediatric asthma, and including Gina has said that you can start off immunotherapy early to prevent the further exacerbation. When you go to severe asthma, there is no role, because less than FE1 by 70%, if you give immunotherapy, they may have again a bronchospasm. So in the Western world, and please do note, immunotherapy is only for few. One is the commonest is how dust mite, and you should also have a standardized allergen. Without the standardized allergen, you give immunotherapy because you need to give for 3 to 5 years. And what they have looked into the studies is that in the accepted worldwide is a sublingual immunotherapy given for 3 to 5 years. There was a decrease or progression from atopic allergic rhinitis to asthma. And whoever on asthma, their medications have come down. So there is a ray of hope when you have a standardized allergen. Yes, there is a definitely, you can try, and when you have a single allergen rather than multiple allergens, because you may have cross reactivity, when you add 2-3 allergens, whenever they are doing an allergen immunotherapy, saying that I'm putting 2-3, no. Please do look at these standardized allergens and which company they've been using. Previously, Allergo Pharma used to supply this kit, and you need to do an underfund. So started with immunotherapy. After 2 years, the child had decreased the amount of symptoms. We could reduce the inhalation therapy, and the child is doing good. So the take-home messages are, all that disease is not asthma. Please do remember, because I've started with a typical case of an asthma, because it's a constellation of symptoms. It is not a single definition. And you need to know the asthma is a clinical diagnosis, definitely, but it has to be supported by spirometry. And you need to take the history diagnostic elements, which includes your, again, your spirometry wherever possible. And whenever you don't have that spirometry, you are giving a therapeutic trial. If it is responding, yes. So if you have a cough which is for more than 8 weeks, which is dry cough, not a wet cough. When you have a wet cough for more than 8 weeks, you should think of protracted bacterial bronchitis. When a wet cough, when it is a dry cough, think of cough variant asthma. Give a inhaled corticosteroid, give a trial. If it is working, then you label them as an cough variant asthma. So you need to know, as I said, TH1 high and TH2 low. So the endotypes and genotypes, because when you're in doubt, please do refer to a qualified pulmonologist where they can definitely do. And sometimes your biological markers would there are a number of markers which is common. TH2 is your the cytokines would be definite. That is the reason anti-IL-5, IL-13 has been come out and they've been working. And most important, never, because including in the pulmonologist fraternity, we do discuss cases among ourselves, so that if you have a difficult case, the idea, so multidisciplinary approach and taking advice would be definitely helpful. And with this, I would end up my presentation. If there are any questions, I would like to take, and I would thank everybody for your patient hearing.
Thank you, Pawan. It is an excellent presentation, and now we know that everything that wheezes is not asthma, and we need to think of many other things, like you already shown us in different cases, like allergy, your laryngeal problems, and mucociliary dyskinesia, and many more things are also associated with wheezing. So when to refer to a pulmonologist is also a important thing. I have one question from my side, then we will take some from the audience if something is there in the chat box. How do we do spirometry in less than 6? Because you told spirometry is a gold standard for diagnosis of asthma in more than 6 years. more than 5 or 6 years, or those who can
Yeah. I
those
do
who
agree.
can those who can do. But what we do for less than 6 years of age or 5 years of age?
So that is a good question. That is the reason I haven't mentioned about the forced oscillatory.
Because whatever cases you mentioned were all above 6 years of age.
That is the reason I have started my second slide with modified asthma predictive index till 5 years of age, because we don't have much of the documentation. This is where we need to look into. There are certain things which are coming out is an impulse oscillometry, but we don't have a standardization. So till less than 5 years of age, please do mention that is viral triggered wheezing or multi-triggered wheezing, whatever it is. And sometimes if the child is not responding to your normal way of systemic steroid, then you think of neutrophilic type and give a course of azithromycin. That is what they are looking into. So till 5 years of age, you're not going to talk, because under 5 years is a big terminology where you have so many other diagnoses which we need to look into other than your viral triggered or multi-triggered wheezing. So please do keep your modified asthma predictive index, and that should be more than 4 wheezes per year.
Tukaram sir.
Thank you, sir, for such a wonderful session by you. We have to always keep in mind to when we are seeing the respiratory cases, all wheezes are not asthma. We have to look the clinically with the all the investigation approach while depressing the asthma with vocal cord dysfunction, tracheomalacia, and some ciliary dyskinesis. Thank you, sir.
Thank you, sir. These are all the real-time case scenarios which are presented. The only sincere request is every cough or everything who comes to us with only noisy breathing, we keep on giving nebulizer therapy. That is what we need to tell, that this is not each time that nebulizer would create. Because once we start, because it's in one of the sessions, one of the doctor asked me, we generally say, please give with oxygen. Nobody looked into the data with oxygen. Really, is there any VQ mismatch? We haven't looked into data. Sir, we are using since long. Why should we use? As I couldn't answer, because we don't have a data where there is a VQ mismatch. In spite of not being giving with oxygen, at home people are being taken. If you take 100 patients, only 1 or 2 might come up. We don't know what exactly. But I have seen patients in Australia who had been taking only the levosalbutamol, have died with 12 canisters there. So instead of giving your preventer therapy, inhaled corticosteroids, which includes, I haven't touched about the MART therapy, where maintenance and reliever is the same, where you have the budesonide with formoterol, that is in adult people, more than 12 years they've been using. So in where I have worked, the we use solmetrol with pictexon there, even though there are no studies, smart therapy, you can give as a maintenance and a reliever therapy. And there are certain, the maximum dosage is 54 microgram of your formoterol. So you can give those intermittently for an adolescent age group. I haven't touched upon again, there is a synchro breathe, because each patient DPA, when you have an acute exacerbation, dry powder inhalation therapy would be very difficult, because the child would not be able to create such much of pressure. So the synchro breathe would be much, and I would most of the adult colleagues of mine are also started using for an older age group the zero stat spacer. So we need to emphasize the spacer and the washing techniques before we send them. And so that is the reason I brought you, because the mucociliary problem, which I've diagnosed only a month ago, because the child was being treated, and 1 month down the lane, I just did a genetic analysis. That's only the cheapest way, because I have to send to somewhere else, because there are only certain centers who do the nasal brushing. So hope I have created some awareness that there are certain things, and also that every wheezing is not asthma. And please don't ever say this. I would prefer nebulizer therapy only for cystic fibrosis or PCD patients where they have an airway clearance problem, where you need to give a 3% or 7% hypertonic saline. Prior to that, we give an inhalation, levosalbutamol, to prevent the airway leaching. Other than that, you need to, if everybody are on the same page, then the nebulizers will not go, and we should only emphasize on inhalation therapy. So everybody, please do that thing in the World Asthma.
Thank you, Pawan. I have seen few deaths of VQ mismatch during my residency also, and when I was working in Mumbai for some time. And in severe respiratory distress, never go for a nebulization with salbutamol alone. Even when I was doing residency, we used to give nebulization with oxygen, and never used the nebulizer machines in my residency in KEM. So take home message is never use nebulizers in OPD where you are not sure how much VQ mismatch is going to be there.
I can give you some Indian jugaad. Because only thing is that if you keep on oxygen, the cylinder is too costly. Oxygen has been so purchasing. You need because if you have to give a oxygen nebulization, that would be 7 to 10 liters. You have to put it. The other way around is put an oxygen here through the side port and give. That is the best way. That is if you want to give oxygen, and you have to give with oxygen. So there is one question. It is very difficult to.
It is from a adult chest physician actually. So you can answer, Pawan.
Yeah, it is very difficult to do a spirometry below 10 years of age. Will you explain? You explain easier way to do spirometry in children, or is it okay to do peak flow meter? Sir, peak flow meter has been abolished long ago, except for the follow-up, where you have a brittle asthma, where they come with acute exacerbations without knowing. So we give them the peak flow meter. Previously, they used to do a peak flow meter pre and post, but nowadays we generally don't give, and it's only for the monitoring purpose we do a peak flow meter. For less than 10 years, in less than 5 years of age or 5 years of age, I give a tissue paper. I'll show you a live demonstration. This is what I've been taught in Australia by the respiratory therapist. I'll give them the tissue paper, ask them to blow hard as possible, give them training, and ask them to come back, so that would be easy for me. And if I give a spirometry to any of you, it is very difficult, because if you do on yourself, it is you will understand. So the most important thing is that you need to train. And I would say, first it would be a failure, no problem. And you do repeatedly, definitely it will come up. So I would, more than 5 years of age, I could, in spite of all the career what I've done, I would only succeed in only one patient who is a 12-year-old who did in first attempt absolutely normal. Fabulous, fantastic. Rest of them had taken second or third attempt. So kindly do practice. It's not a big difficulty.
Thank you, Pawan. Now I think we will move to our next.
Sachin.
Yes.
Sachin.
Yes.
I have one question, sir. It was a nice session. I have a question. In day-to-day practice, when we diagnose asthma and we start on inhaler therapy, it is very difficult to counsel the parent about inhalation therapy and continuation, because they think that it is a stigma. Only a few points how to counsel them, it will be better.
Excellent, sir. So I would tell you, sir.
The time, Pawan, most of the time they think it will go for addiction of
Correct.
addiction. That is the main.
Correct. I do agree. It's everywhere. Any part of the country, it remains the same. So the only thing is that you are brushing your teeth, you're not getting addicted. That's why you can say. But the people are being what you call passion about the movie. So you tell the movie artists like Priyanka Chopra, Amitabh Bachchan, who have been on inhalation therapy since long. Volo Glere, because every company has been taken a brand ambassador of a movie artist, so that Zindagi, that is what every company. So it is very difficult to convince exactly, but the only thing is that I keep again one more. Sorry, this airway tubing, and show how they do the look. You can ask from your Cipla guys or anywhere and show. So this is the normal airway. This is what when you have an asthmatic and when you have not been under control, this will go. And if this is there, you have exercise-induced bronchospasm, intermittent symptoms. To keep this way, you need to have that inhalation therapy. They will ask, "Sab, bhai sab, kyun ye vaap nahi laga sakte?" If you take the nebulizer therapy, my child is very comfortable with nebulizer, not with an inhaler therapy. It is cumbersome. Two things you need to say. Nowadays, they come, the 6,000 wala without electricity has come. I don't agree. The only thing is that oral deposition is much more than your inhalation therapy. It has to go to lungs. So, idhar tak jaane ke liye you should have, you need to inspire. holds breath for as much as 6 seconds for a pediatric age group. So if you teach them and you demonstrate them, then they will understand. Only thing is that why they don't follow, we don't have time. Give time for an asthmatic, definitely, because in my practice I've seen when I've given time, people have been following. Only this thing, once you give an inhaler therapy and tell them these are things, they don't come up follow up. They keep on purchasing the inhaler therapy and they come back. And I've seen a patient, I've given levosalbutamol to take every 3rd hourly, it's like 2 puffs, and she came with next day with canister completely out. And I've also seen people demonstrated how to take an inhalation therapy. I didn't show that video. He was doing the inhalation therapy outside and he was putting the mask here with the canister on. So you should see all those things until unless you ask them to bring up with the spacer and mask with them each time, because you need to train one of the staff. They have to teach them outside, come again inside, show us, and whenever they are not using for a longer duration, they need to prime up the spacer. Give time, sir, they will definitely listen. Only thing is that the stigma, you need to tell, including a 25-year-old female from a Bangalore having intermittent asthma, had an acute exacerbation, stigma of not taking inhalation therapy. Once she took it, she was absolutely fine. Stigma of not getting married if I have an inhaler. So that is the reason they come with synchro breathe, where it is, you need not have this equipment. Adolescents are the biggest problem with us. And you need to satisfy 3 people, sir. Papa log, mummy log mante, magar ajji ajoba nahi mante, sir. So whenever they come, those are the people who keep on telling, if you say something, doctor ko kuch nahi aata, hamare zamane mein aise darne se sab ho jayega. So you need to counsel the whole family. Counseling is the only art and you need to take time. It's not to bol sakta hu, sir. Because in my practice, I've counseled and nobody have changed it. Only this thing, sir, they keep on wiping. Sir, अच्छे से साफ किया और ये काम नहीं कर रहे. So how much ever time I say, don't साफ मत करो cloth से, only lukewarm water से dip it and dip right. That's it. In spite of idling and the spacer, according to the company, you have to change every 6 months. India में इसमें कोई नहीं करते, sir. 1 year, 2 years, 3 years until it's functioning well. How do you know it's functioning well? If it's not coming with acute exacerbation. That is as simple as it, sir.
Thanks, Pawan. I think counseling and giving time is the most important thing. That is what everyone knows, and all physicians, all chest physicians also know. Our next speaker is already waiting, and I request Dr. D.S. Kulkarni sir to chair the session and introduce our next speaker, Dr. Sunil Wagmare sir, who is a chest physician. D.S. sir.
सचिन डीएस सर दिसत नाही आहेत बहुतेक.
हे संयुक्त कुलकर्णी कोण आहे? Shall I? सर तुम्ही इंट्रोड्यूस करता?
तूच करून दे सचिन.
ओके. Dr. Sunil sir has done his MBBS from Grant Medical College, JJ Hospital, and done MD Pulmonary Medicine from LTMC Sion Hospital. He was senior resident at VM Government Medical College and Hospital Solapur, and Specialty Medical Hospital at YCM Pimpri. He was consultant pulmonologist at YCM Pimpri from for a few months, and he has done he has worked as an intensivist at Sterling Multi-Speciality Hospital, Nigri. He's working in Bid since 2019, and he's He's in private practice at Pulse Hospital, Bid from November 19. Sunil, sir.
Yeah. Thank you, Sachin, sir. First of all, I thank the IMA Bid branch, Bid Pediatrics Association, presidents, all secretaries, and seniors and colleagues for inviting me to give a small talk on the occasion of World Asthma Day. Yes. Sir, is my screen visible to all? Hello?
Yes, yes,
Yes, sir.
it's visible.
Yes, it is visible.
On the occasion of World Asthma Day, that will be on tomorrow, 3rd of May, the selection of topics done by the Bid Pediatrics Association are good. It is not usual topic to describe the asthma presentation and usual treatments, basics. The topic that was chosen by Dr. Pawan Kalyan sir was extraordinary to differentiate, to distinguish all the mimics of asthma from the common asthma problem in pediatric population. The one more topic that I have decided to speak on is difficult to treat asthma. Tomorrow on 3rd of May will be the World Asthma Day. It is celebrated on first Tuesday of each May every year. The theme for the World Asthma Day tomorrow is closing gaps in asthma care. We all know that there are lots of gaps in the treatment of asthma in every aspect, regarding diagnosis, regarding awareness in both treating healthcare workers as well as general population, parents, patients. There are gaps in the diagnosis, there are gaps in the counseling, there are gaps in the available treatments. Not all patients are receiving the proper care that they should be receiving. These are the basics of asthma. Asthma is most common chronic non-communicable disease. It is characterized by variable respiratory obstruction and symptoms such as wheezing, chest tightness, cough, and shortness of breath. The goals of the asthma treatment described by Gina are of symptom control and risk reduction. In symptom control, patient should have few asthma symptoms, no sleep disturbance, no exercise limitation. And in risk reduction, the normal lung function should be maintained. There should be reduced number of flare-ups or exacerbations. The treatment should prevent asthma deaths and avoid medication side effects. Previously, the GINA guidelines used to describe use of SABA even for 1 to 2 weeks is associated with that was associated with adverse effects such as beta 2 receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness. The higher use of SABA is associated with adverse clinical, increased exacerbations, even deaths. So in 2019, the landmark change that was done in GINA guidelines is they have recommended against the only SABA use in step 1 in adults and adolescents. The patient should not receive short-acting beta-2 agonists such as levosalbutamol only. It should always accompany with inhaled corticosteroid. GINA now recommends that all adults and adolescents with asthma should receive ICS containing controller treatment to reduce the risk of serious exacerbations. ICS can be delivered by regular daily treatment or in mild cases as needed low dose ICS and formoterol. This is the usual steps that are followed in the treatment of asthma. I think everyone is aware of these treatment recommendations by GINA. So, asthma is classically differentiated into controlled, partly controlled, uncontrolled asthma. So, what is uncontrolled asthma? Uncontrolled asthma is presence of frequent symptoms and flare-ups, exacerbations. In these patients, many may be having mild asthma. That is, the asthma symptoms can be well controlled with low dose inhaled corticosteroids if taken regularly. The criteria for uncontrolled asthma include exacerbations, poor symptom control, lung function impairment, or variable combination of these. What is it? Difficult to treat asthma. Difficult to treat asthma should be differentiated from difficult to treat patients. Asthma that remains uncontrolled despite treatment with high dose inhaled corticosteroids or other controllers, or that require such treatment to remain well controlled. The contributing factors that may include are incorrect diagnosis, incorrect inhaler technique, poor adherence, and other comorbidities. So in difficult to treat asthma, I will be talking mainly on the gaps such as incorrect diagnosis, incorrect inhaler technique, poor adherence, associated comorbidities. Severe asthma. What is severe asthma? Severe asthma has many different, it is defined by it is defined in different wordings. Asthma that is uncontrolled despite maximal optimized therapy and treatment of contributors worsens when high dose treatment is decreased, that is relatively refractory to corticosteroids. Again, another definition of severe asthma is severe asthma that is uncontrolled despite high dose ICS along with long acting beta 2 agonist LABA, or that requires high dose ICS LABA to remain controlled. In the patients with asthma, severe asthma make up around 3 to 10% of the population of adults with asthma. So, in uncontrolled asthma, we have difficult to treat asthma, and in difficult to treat asthma, we have a subset that is severe asthma. To define uncontrolled asthma, in the above panel, we can see criteria used to define, that is poor symptom control asthma, that is asthma control questionnaire, that is more than or equal to 1.5, or frequent or severe exacerbations, 2 or more bursts of systemic requirement of corticosteroids, serious exacerbations, or airflow limitation. Controlled asthma that worsens on tapering of high doses of inhaled corticosteroids or systemic oral corticosteroids. The threshold for different inhaled corticosteroids that is used in pediatric population from age 6 to 12 years and in adolescents and adults more than 12 years of age. It is shown in the second panel. So what proportion of adults with asthma have severe asthma? In all asthma patients, around 1/4 or around 24% patients have high intensity treatment requirement, that is high dose of inhaled corticosteroids along with longer acting beta-2 agonists. Out of these high intensity treatment requirement patients, 17% are difficult to treat asthma. That is high intensity treatment requirement. Even on high intensity treatment, patients have poor symptom control. Out of these, 3.7% patients are having severe asthma. That is, in patients requiring high intensity treatment, they have poor symptom control, and even on good adherence and proper inhaler technique. GNAT 2021 has described the flowchart of steps to follow in the management of difficult to treat asthma. There are total 8 steps. I will be showing them one by one. First step is in this flowchart. You can see first is confirm the diagnosis, whether it is asthma or any differential diagnosis. Second step is symptoms, exacerbations, poor quality of life, such as incorrect inhaler technique, suboptimal adherence, comorbidities including obesity, GERD, rhinosinusitis, or sleep apnea, modifiable risk factors, trigger factors, indoor, outdoor, presence of smoking, environmental exposures, allergen exposure, or use of medications such as beta blockers or NSAIDs. Overuse of small short-acting beta agonist relievers, anxiety, depression, or social difficulties. In step 3, we need to optimize the asthma management. Step 4 is review response after 3 to 6 months. In step 5, we have. In step 5, we have to assess the severe asthma phenotypes, endotypes, with the help of biomarkers. In step 6A, I will be discussing on the consideration of non-biological treatments. In step 6B, addition of biologics in the management of asthma. In step 7 is review of response. Step 8 is continuing with the management. Whenever there is a difficulty in managing, it's difficult to, we have come to the consideration of difficult to treat asthma. First step is we need to confirm the diagnosis of asthma. If the patient is really having asthma or any differential diagnosis, for the confirmation of asthma, we have different tests such as pulmonary function test, spirometry, or if it is normal, we can go ahead with bronchoprovocation tests. When implementation in the confirmation of diagnosis, the patients who are previously considered difficult to treat asthma, they may be 50% of these out of these patients may be reclassified into some other differential diagnosis. Next step is to implement an adequate trial of therapy with high dose of inhaled glucocorticoids and LABA. Accessing adherence and inhaler technique is critical. In every patient that is coming to OPD, we have to check for the patient's inhaler purchase records, inhaler dose counters, the technique of the patient. Patient may be using inhalers directly, or maybe using synchro breaths, or maybe using with spacer, any type of. They may be dry powder inhalers, or maybe pressurized meter dose inhalers. with the patient's uh, understanding, we have to go ahead with the their adherence and adherence of the inhaler technique. There is an integrated multidisciplinary approach to assess and manage difficult to treat and severe asthma. The smart therapy or MART therapy, that is maintenance and the simultaneous maintenance and quick relief therapy. It involves low dose of inhaled glucocorticoid and formoterol at the patient's both regular therapy as well as quick relief therapy. It reduces both exacerbations and allows the use of low doses of inhaled corticosteroid treatment that is approved by many regulators. In step 5, we have to assess the severe asthma phenotype and the factors contributing to symptoms and decrease quality of life and increase exacerbations. There is a concept of type 2 inflammation, that is patient that is described by increased blood eosinophils more than or equal to 150 per microliter, nitric fraction of exhaled nitric oxide more than or equal to 20, sputum eosinophilia more than 2%, asthma that is driven by one or more perennial allergen. We have to investigate the patient for the possibilities of comorbidities or differential diagnosis with the help of different investigations such as CBC, CRB, IG, total IgE, chest X-rays, CT chest, and in some cases differential diffusion capacity of carbon monoxide. Use of skin prick tests. In this step 6A, we have to consider non-biological treatments. The different phenotypes that are described difficult to treat asthma that are depend on different observable characteristics of disease such as morphology, development, biochemical or physiological properties of behavior. Patients with identified phenotype of obstructive lung disease may share a cluster of clinical or functional or inflammatory features without any implication of common underlying mechanism. The different phenotypes that are described are, as you can see, eosinophilic airway inflammation, neutrophilic airway inflammation, mixed inflammation, possible granulocytic inflammation, and hypersensitive and variable obstruction. Endotype, subtype of disease defined functionally and pathologically by distinct molecular mechanism or by distinct treatment responses. Among patients with obstructive lung diseases, there are likely to be several specific endotypes associated with divergent underlying molecular causes and with distinct treatment responses. These endotypes may or may not align with clinical or inflammatory phenotypes identified from studies related to asthma or COPD. The endotypes that may be emphysema due to alpha-1 antitrypsin deficiency. Different biomarkers that are used define that are Biomarkers are defined characteristic measured as an indicator of normal biological process. These include fraction of exhaled nitric oxide, blood eosinophils, or periostins. In step 6B, we have to consider addition of biologics targeting type 2 inflammation. Before decide whether a patient needs biologics as an add-on therapy, there is a recommendation by GINA to give a trial of tiotropium, low-dose tiotropium, which is a long-acting muscarinic antagonist. Tiotropium, it increases lung function and the time to first exacerbation. Other drugs that may be considered include azithromycin. We have to consider add-on type 2 targeted biologics for patients with exacerbations of or poor symptom control on high dose ICS and LABA in patients who have eosinophilic or allergic biomarkers and they need maintenance oral that is high dose steroid requirement. There are different biologics available and being studied currently worldwide. The first biologic available is anti-IgE, that is omalizumab. Anti-IgE omalizumab is a monoclonal antibody that binds to free IgE, preventing activation of cells such as mast cells, basophils, and dendritic cells, and down-regulating the high-affinity receptors for the Fc region of IgE. Omalizumab is available for clinical use in US since 2003, and it is being used in India. Previously, it was being used in the treatment of asthma. Now it is also recommended in the use of nasal polyps and chronic spontaneous urticaria. When added to inhaled glucocorticosteroids, omalizumab reduces severe exacerbations and hospitalizations by approximately 85%, and it allowed lower doses of inhaled glucocorticoids and small decrease in the reliever therapy. In patients with uncontrolled severe allergic asthma and a history of exacerbations treated with high-dose combination therapy, omalizumab reduced exacerbations by 25 to 35%. In the uses of omalizumab, baseline IgE levels are not predictive of response, but baseline IgE levels are done in the calculation. Baseline IgE levels and body weight are used to calculate the drug dosage. Anti-interleukin 5. Two anti-interleukin 5 are being studied, and one is currently being used in the treatment of asthma, that is mepolizumab. Another one is reslizumab. Interleukin 5 plays a central role in promoting eosinophilic inflammation. Anti-interleukin 5 monoclonal antibodies are now available for the treatment of patients with severe eosinophilic asthma and recurrent exacerbations. Next is benralizumab, which binds to interleukin 5 receptor, thereby producing eosinophil apoptosis, is nearing FDA approval. The majority of studies performed involving patients with severe asthma have been conducted with mepolizumab. In patients with 2 or more exacerbations in the previous year and a blood eosinophil count of at least 100 per microliter. Mepolizumab reduces exacerbations by 40 to 60% as compared with placebo, and mepolizumab has also been shown to allow a mean 50% reduction of oral glucocorticoids. Next,
very good. The conference.
Next is blockade of interleukin 4 and interleukin 13 signaling. Blockade of interleukin 13 has the potential to alter airway inflammation and smooth muscle reactivity. The drugs that are being studied are lebrikizumab and tralokinumab. Next drug that is being studied is dupilumab. It is a fully human monoclonal antibody to the alpha subunit of the interleukin 4 receptor that blocks both interleukin 4 and interleukin 13 signaling. Biologics that are currently available, and those are being already approved, and those are in phase 3 testing. Out of these, omalizumab, mepolizumab, and rizumab are already approved for the use of difficult to treat asthma. Step 7 is review of the response in the form of symptom control, decreased exacerbations, improved lung function. If there is good response to type 2 targeted therapy, we have to re-evaluate patient every 3 to 6 months for oral treatments. Consider decreasing or stopping the oral corticosteroid first, then stopping other add-on medications. For inhaled treatments, consider decreasing after 3 to 6 months, or continue at least moderate doses of inhaled corticosteroids. So, re-evaluate need for ongoing biological therapy. If there is no response to type 2 targeted therapy, we have to stop the biological therapy, review the basics, differential diagnosis. Again, we have to check the inhaler technique of the patient, adherence, presence of associated comorbidities, presence of drug side effects. Consider high resolution CT chest. We have to reassess different phenotypes and other treatment options. In step 8, we have to continue to optimize the management as described in section step 3, that is rechecking inhaler technique, rechecking adherence, comorbidity management, patients' social and emotional needs, and 2, communication with the primary care physician. One more treatment modality that is being used is bronchial thermoplasty. Bronchial thermoplasty is approved in 2010. It involves radio frequency ablation of the airway smooth muscles during different settings. In bronchial thermoplasty, the heat-induced smooth muscle ablation is done in lower lobes and upper lobes. The thermoplasty technique is very uncommonly used because it is not available at all the centers. It is only available in institutions. The conclusions in the treatment of difficult asthma are: patients who present with uncontrolled asthma despite use of high dose pharmacological therapy have high morbidity asthma. In many patients, asthma can be well controlled after optimizing what is currently considered standard asthma treatments, including improving inhaler technique, adherence to the treatment, and systematically addressing coexisting comorbidities or conditions. With advances in identification of phenotypes with various pathophysiological mechanisms, the heterogeneous underpinnings of the disease are being beginning to be exposed. New targeted treatment options are available for substantial proportion of patients with truly severe asthma who have persistent type 2 inflammatory type 2 inflammation phenotype despite administration of the high dose inhaled glucocorticosteroids along with oral. Considering the high cost of recent and forthcoming therapies, substantial research is needed to identify the patients most likely to have a response to these new treatments. Thank you. Hello.
Thank you for so nice presentation. If anybody has questions, please post in the chat box or can ask directly. I think nobody has questions. I will request Dr. Pradeep Shirke for vote of thanks.
First of all, I am giving thanks to Dr. Mujahid, who has attended this session. By seeing his name in the list, I was so surprised and happy. And we all are eager to meet him. Thank you, Mujahid. And thanks to both the speakers, Dr. Pawan Kalyan, Dr. Sunil sir, for excellent talks. Thanks, Dr. IMA President, Dr. Pangdikar sir, IIT President, Dr. Joshi sir, and special thanks to Dr. Sachin Jetlia for coordinating, and for all the members who have attended these sessions. Thanks to all of you. Thank you, sir.
Thank you. Thank you, everyone.
Thank you, sir.
For information of everybody, we have Zoom link of IMA IIP, which can be continued for unlimited time and has live YouTube live. We can send this talk. So anyone want from IMA IIP or from BEAT requires to have a educational program for parents, for patients, or for doctors, we can use this link. Thank you.
Thank you, sir.
सचिन लाइव बंद करतोयस?